So it's my time. I would like to invite the next speaker. He is Dr. Upul Vikramarachi, consultant cardiologist, a consultant interventional cardiologist at Lanka Hospitals. It's over to you, Upul.
Thanks very much for the kind introduction. Excuse me. Good afternoon, everyone. Nice to see a full house. I'm going to talk on types of anticoagulants and their use. And I do apologize in advance for the repetition. There's quite a lot of overlap, but I hope it will help to consolidate some of the knowledge that you have gained already through Dr. Ali's lecture. Right. So, what is an anticoagulant? You've heard this already, a medicine that inhibits one or many steps in the coagulation cascade. So making, in layman terms, making your blood thinner or to clot less likely. Classifications could be done mainly in couple of ways. I thought one depending on the route that you give, and the second one based on the mechanism of action. So oral anticoagulants, intravenous anticoagulants, and subcutaneous anticoagulants. Oral ones, as we know, the most commonly used one is warfarin, and then the direct oral anticoagulants, which are the DOACs. Intravenous, mainly we use intravenous heparin or unfractionated heparin, and in Americas they use bivalirudin quite a lot, and I don't think that we use bivalirudin here in Sri Lanka much. Subcutaneous, low molecular weight heparin. The commonly used ones, the enoxaparins, fondaparinux for acute coronary syndrome, even though we don't use it much here, and then dalteparin and all the other types. So this is the classification based on the route, either oral, IV, or subcutaneous. Then classification on mechanism of action. Vitamin K antagonists. So basically, they all act at various steps on the coagulation cascade, as described by Dr. Ali. I'll put a diagram later on as well. So vitamin K antagonists, they inhibit, as the name suggests, stops the vitamin K dependent formation of clotting factors 2, 7, 9, 10. The direct oral anticoagulants inhibits factor 10A. They are mainly the apixaban, the edoxaban, rivaroxaban. You've heard of all these names. The direct thrombin factor 2A inhibitors like dabigatran. So unfractionated heparin, the IV ones, they inhibit factor 10A and also inhibits the conversion of prothrombin to thrombin. Bivalirudin at factor 2A level. Low molecular weight heparins. Fondaparinux inhibits just factor 10A, whereas the other low molecular weight heparins can inhibit both factor 10A and factor 2A. So it's a little, not that complex, but maybe sometimes too much detail, I feel. But anyway, it's important to know how these medications act if we prescribe and if we look after the patients who are taking these medications, I feel. So this is a diagram showing various steps of their action. So we can look at unfractionated heparin, where it acts mainly on factor 10A and also factor 2A. These are the two main steps. So most things would act here, and factor 2A, unfractionated heparin, low molecular heparin. The direct oral anticoagulants will act only at factor 10A. Sorry, can you go to the next slide, please? Thank you. Next is their uses. So we'll go one by one as what are the most commonly used indications with these various anticoagulants. Warfarin is the most commonly used one, as you all know. As Dr. Ali said, mechanical valve replacements, that's still a must. And then atrial fibrillation with mitral stenosis, the recommendation is to use warfarin still, and DOACs are not really recommended. The other places are where the DOACs have already been tried and they're not tolerated well, or they've had issues with other interactions. Then you can use warfarin in those patients. Left ventricular thrombus, still the mainstay of treatment is warfarin. and other thrombosis with other thrombophilia such as antiphospholipid syndrome. The warfarin is the preferred choice of drug still. Sorry, next slide, please. Thanks. So DOACs. So rest of the world has moved very fast in using DOACs. They're pretty much all atrial fibrillations who meet the criteria in CHA2DS2-VASc score for stroke prevention in non-valvular AF will receive a DOAC now. I'll tell you why. The other AF with valvular heart disease, other than mitral stenosis, DOAC is still preferred, and also treatment of deep vein thrombosis, pulmonary embolism, and also prophylaxis for DVT and PE in both surgical and medical patients. You can use DOACs. So you may ask why DOACs instead of warfarin. That's because the scientific study showed that DOACs, at least in one of the studies, showed that in terms of risk from reducing the risk of thrombosis, they are better than warfarin, or at least non-inferior. In terms of bleeding risk, DOACs cause less intracranial hemorrhages, and in one of them, at least with regards to apixaban, there's less intracranial hemorrhage as well as less gastrointestinal bleeding. So that's why that's the main reason why the world has moved towards DOACs instead of warfarin. But there are other important factors, such as the ease of use, where you don't have to monitor your INR levels regularly. You can maintain a therapeutic level constantly without fluctuations. Those are the two main reasons why we have moved towards DOACs instead of warfarin. But unfortunately, in our settings, as we have to understand, there's a cost factor involving, there's no point us prescribing medications if the patients cannot afford it, so we always have to look into that aspect as well. Sorry, next slide, please. Uses of IV heparin. These are only very limited to very specific scenarios now. During PCI, as you heard, we use intravenous heparin quite a lot to maintain an acceptable ACT, to reduce the risk of thrombosis. And then bridging therapy, this is quite important, as Dr. Ali said, whenever there's a patient with mechanical valve replacement who's been admitted for a surgical or interventional procedure, we should always, as nursing colleagues, as important allied healthcare professionals, if someone said to stop warfarin, you should always ask, are we going to bridge this patient's anticoagulation with something else, or are we going to just watch after stopping? So IV heparin is used in these scenarios, partly because it's short-acting nature. So you can maintain IV heparin and stop it before like 4 hours before the procedure and do the procedure safely, a surgery. Then treatment of DVT, PE, unstable angina, the IV heparin could still be used. Then it's very helpful in patients with renal impairment and who are waiting procedures, as I said before. And also in where there are extracorporeal circulation systems are involved, such as cardiopulmonary bypass, ECMO, hemodialysis, as well as intra-aortic balloon pumps. IV heparin is still being used routinely. Next slide, please. Thank you. Low molecular weight heparins. So fondaparinux is mainly used for acute coronary syndrome when it showed better data than the routinely used other ones. But I don't think we have that available very much so in Sri Lanka. We use commonly the enoxaparins and the dalteparins. So both in ACS, non-STEMI and STEMI setting, we can use it. Prophylaxis for venous thromboembolism for both medical and surgical patients. Treatment and also prevention of to prevent thrombus during hemodialysis. Next slide, please. Thanks. As healthcare professionals, it's very important for us to know how to monitor these patients, how much, what's the effect of the anticoagulants on these patients. So it's important for us to know which mode to use and what are the not so helpful measurements. So with warfarin, we all know INR is the way that we monitor how effective the anticoagulation is. And as an antidote, or when I say antidote, if someone comes with bleeding, we can depending on how severe the bleeding, guided by the clinicians, and we can decide whether just to stop and watch or whether we have to reverse anticoagulation. So we can use prothrombin complex concentrate or warfarin or even FFP, all those. With regards to DOACs, like rivaroxaban and apixaban, the measurement should be on anti-factor 10A activity. There's no point doing INRs and trying to interpret INR of a patient who is on a DOAC. We don't do it routinely because we know their effectiveness is constant, but if needed, we can always look for anti-factor 10A activity. And the antidote is coagulation factor 10A recombinant. It's available, it's used. Unfortunately, again, we don't have much. We don't have that available in Sri Lanka, but we can use PCC and even FFP if needed, if you have to reverse these patients. Heparin, APTT ratio. Most time, if you're on heparin infusion, you'll maintain a ratio between 1.5 to 2.5 and adjust the rate accordingly. Usually it's either 4 or 6 hourly APTTRs. Antidote is protamine. Sorry, there's a spelling error. It should be MINE. Low molecular weight heparin, anti-factor 10 activity, and antidote is protamine. It's just a summary of how to monitor these patients and what the antidotes are. Next slide, please. Thanks. Right. What are the other important aspects? I think as colleagues, it's a teamwork, as you know, to look after these patients very well. It's important everyone to be vigilant about what their medications, what other past medical or surgical problems they've had. So always inquire about if they're on an anticoagulant, what is the indication. And as clinicians, I think it's our paramount duty to let the patient know this is why you are taking an anticoagulant, this is your therapeutic range. Whenever you come across a healthcare professional, mention this very clearly. So it's our job, and if someone is admitted, I think it's everyone's job to find out what is it due to and what is the therapeutic range and all that. And if it's not included in the drug chart, to find out, was this intentional? So always clarify with the doctors, or was it a mistake? So we can reinstate safely. Then again, similarly on discharge summaries, on discharge cards, have we missed out on the anticoagulant? If so, is it intentional? Or have we given, like aspirin, clopidogrel, all of that with anticoagulant? Is it intentional? Or very rarely with post-PCI patients, we would use triple therapy, aspirin, clopidogrel, and an anticoagulant for like maybe 4 weeks maximum, but not forever. So if the patient comes after PCI 2 years down the line on all 3 agents, there's something not right. That's been an error. So be vigilant. And then if a patient is admitted for a surgical or invasive procedure, always clarify when to stop the anticoagulant, or give that advice very clearly beforehand when to stop it, and whether there's any bridging therapy that's needed. Other comorbidities like renal impairment, excuse me, like renal impairment and drug doses, because some drugs, the dose will depend on their renal function, and also other pathologies like dengue, liver disease, which can increase the bleeding risk. I think it's all very important to be alert. So in summary, basically, I've spoken about the types of anticoagulants and their use. We said we can divide on the route we take or the mechanism of action and their indications and how to monitor their antidotes and some practical inputs that we have to be all very careful in looking after our patients. I come to end of my presentation. I think the questions will be at later on, isn't it? Right. Thank you very much. Thanks.
Thank you, Upul, for the informative lectures.
Thanks.